This week on the BackTable podcast.
These are so fun though. Like, yes, there's, potential for complications, but these are like some of my happiest patients. And it is so rewarding to be able to have a patient like come into the office. And if you can just like fix it in the office and then they like walk out and they're like, all right. And you see them back and they're like, yeah, it's better. Like, you're awesome. Thank you. And you're like, yeah, like it's a win and it feels good. And then, you never really see them again because I assume they're
good.
Off living their best life and doing well. And so, it's just, it's different than some of your other patients that, you're managing long-term, and they can be really fun, especially when you're taking out like a big, 5 centimeter short
dinosaur fossil. Hello, everyone, and welcome to the BackTable ENT podcast, where we discuss all things ENT. We bring you the best and brightest in our field with the hope that you can take something from our show to your practice. Now, a quick word from our sponsor. Cook Medical's Otolaryngology Head and Neck Surgery clinical specialty strives to provide otolaryngologists with minimally invasive solutions to address unmet needs. Areas of focus include head and neck, otology, and laryngology, with products ranging from a full suite of interventional silendoscopy products and the Doppler blood flow monitoring system to the BioDesign otologic repair graft and the Hercules 100 transnasal esophageal balloon. For more information, visit cookmedical.com/otolaryngology. Now, back to the show. My name is Gopi Shah. I'm a pediatric ENT, and I'm here with, I always say you're going to introduce yourself, and then I'm always like,
it's okay.
And my partner in crime, Ashley Agan. I never let you introduce yourself properly.
I love being your partner in crime.
I always get so excited.
And I'm Ashley Agan. I'm a general ENT, and I'm here today with my bestie, Gopi Shah. Sunday morning, just talking about stones today.
Yeah, so we're going to talk about in-office management of stones. For our listeners, we had an amazing in-depth silendoscopy podcast, episode 25, with Dr. David Cognetti. And just to kind of do a little offshoot, I thought it would be fun to talk about in-office management. You see patients in your office where you manage, if it's right there or something you need to do in the office, you do that pretty frequently, yes?
Yeah, it's not infrequent that patients come in with salivary stone, and possibly there is an in-office type of procedure that could help that's worth discussing sometimes. So it's nice to have that in your back pocket to be able to offer to patients.
So before we kind of get into the nuts and bolts of the actual management in office, and I know we did a very in-depth discussion with Dr. Cognetti, just for a quick review, how do these patients usually present to you, and what are some of the questions that you ask every time that's always on your checklist of stuff?
So most of the time, patients have been seen by their primary care doctor or in the ER, and someone has already made the diagnosis that they have a stone. That's probably maybe 80% of the time, 80 to 90%. So most of the time, someone's gotten a CT and there's a stone there. And so like the chief complaint on my schedule will say, sialolithiasis or salivary stone or something like that. The important things that I'm asking them about are, what kind of issues is this stone actually causing? So, patients will say that when they eat, sometimes they'll get some pain and swelling of the gland that, persists during their meal and maybe lasts, 30 minutes to an hour afterwards, and will kind of slowly go down on its own. Sometimes there will be a history of like a really bad sialadenitis that had to be treated with antibiotics. And maybe that was the first thing that made them notice that there was something going on there. And sometimes it's incidental. So sometimes I have patients who got a scan for something else, completely different, and there happens to be a stone there. And when I say, do you have pain when you eat? Have you ever had a salivary gland infection? Do you, anything? And it's like, nope. So I think it's really important to know that salivary stones are pretty benign disease. They're not going to turn into cancer. They can certainly cause a lot of symptoms. They can cause, people to have recurrent infections. They can cause pain when you eat. But if they aren't causing symptoms and a patient is really trying to avoid surgical intervention, that's pretty reasonable to have that discussion. And, sometimes patients just want it out because there's a concern that maybe someday it will cause symptoms, which I think is reasonable as well. But that's where that shared decision-making comes in.
So usually you said they have a CT. Is an ultrasound common as well when they come to you? Or do you usually have something that you can look at more with the anatomy?
Yeah, that's a good question. CT is way more common, but I think ultrasound is helpful. And sometimes, if I'm seeing the patient first and I have that suspicion, I may get an ultrasound because it does allow you to see perhaps, like a dilated duct behind the stone. You're able to see the anatomy of the salivary glands and, the shadow of the stone. So if you can't get a CT for some reason, or maybe, the patient is really worried about their radiation exposure and they would prefer an ultrasound, I think ultrasound is great at looking at salivary gland pathology.
I know we're kind of talking about the gland and the duct. Would you say that we're talking about pretty much the submandibular gland and submandibular duct, yes? Or is it common that you see parotid stones?
Yeah, there's some parotid stones that'll come in too. I would say as far as being able to do things in the office, it's far more common that that's in the submandibular gland and duct. I have maybe seen a handful of patients that have a stone that's literally right at the, distal parotid duct where it's like almost in the mouth. Like if it's right there, I think that's reasonable to, go after that in the office if they would like it. But a lot of times the parotid ones will present maybe a little, out of reach. And those we tend to start talking about silent endoscopy more to be able to kind of see and get back there better. But it just depends. But I would say you're right. Most of them, vast majority are submandibular.
Okay. So tell me about your exam. What are you looking for? Is there any specific tips or tricks about the palpation that you do?
Yeah. So I'm always wearing my loupes with a headlight so that I can really, examine the punctum and be able to see if saliva is kind of flowing out from there. So a lot of times I will kind of, if you're looking in the floor of the mouth, I'll dry up the mucosa with like a piece of gauze so that it's easier to see if you're able to get saliva to flow, right? I'll have the patient push their tongue to the roof of their mouth because that kind of brings everything up. And then I will massage the gland in question first to see if anything comes out. And sometimes you can still get some normal salivary flow from a side that has a stone because sometimes the stone has gotten so big that it dilates the duct a little bit and, you can get some saliva to kind of squeak around it. Sometimes it might look, cloudy or, milky or yellow because maybe there is some chronic infection going on. Sometimes there's nothing that comes out. And then sometimes, you do that and then the stone, if it's moving within the duct, sometimes it'll just like come right up to the, to that distal duct, at the punctum, and it kind of just sits right up there for you. And you're like, oh, hello, like there you are, that's it. And then I'll do the other side too, just to kind of, as a comparison to see what the salivary flow is on that side. And I'll do the parotids as well. I usually do all four just as a part of my kind of normal routine looking around. And then I always palpate. So I'll do like a bimanual palpation where there's one finger in the floor of the mouth and the other hand is on the outside, kind of pushing the gland up towards you. And for, most stones, you should be able to feel it. Unless it's very small, if it's only, 1 or 2 millimeters, you might not feel it. But, it's usually palpable. Even the ones that are like stuck back at the hilum of the gland, in that very proximal duct, if you push the gland up towards you and you kind of slide your finger all the way back, usually you can feel that stone. And so I think that's helpful for me in assessing the likelihood of being able to take it out transoral. If it's kind of fixed at a certain spot and I can feel it really well and access it, then I feel a lot more confident about being able to get it out through the mouth. If it's really far back and really big, that may not be possible. If it's moving around, that obviously makes it a lot more challenging. So it kind of helps me get a lay of the land and assess what we're dealing with, what the possibilities are. The other thing is just assessing how well the patient can tolerate having your hands in their mouth, because some people immediately are gagging, and it's just their gag reflex is too sensitive, or they just can't really tolerate it. That's probably not going to be a great office procedure candidate.
And I feel like the position of the inferior, like the lower teeth, if they're facing towards the tongue, like you just don't have enough room, I feel like, that can make the exam and even finding the punctum difficult.
Yeah, or mandibular tori.
Oh, yeah.
That can really make it challenging. I remember a patient, she was probably in her 80s, who had really prominent mandibular tori and was really trying to avoid going to the operating room. And we were able to get it done, but it was a lot more challenging than my other patients. So yeah, that's a really good exam consideration of just being able to and for, with mandibular tori, that's going to make it hard whether they're in the office or in the OR, because it's just kind of this fixed.
The same anatomy.
Yeah,
it's not going anywhere.
Just there.
Can't shave those down. Okay, so if the ideal stone is going to be the one that's not moving around, that's not that proximal, if you will, that's a little bit more distal, closer to the duct, that's pretty consistent when you feel it, and you can feel it pretty good. And it's going to feel hard between your hands, not like a fullness or,
Right.
It's going to feel hard.
It's obvious. Yeah. Yeah, I would say. And the chip shots, the ones that are really easy are the ones that are right there at the punctum, and you can almost, it's almost like you see it already. It's like it just needs just a little, the duct just needs to be opened just a little bit, and it's going to slide out on its own. It's almost, the body is delivering it to you. Those are the easy ones. But most of them might be, in that, distal third of the duct, so that they're accessible, they're palpable, they're not really sliding around on you. Those are going to be easier to go after.
So what about the patient that doesn't come in with any imaging? They have the classic history of when they eat, after they eat, they have swelling and pain. And, you do your exam and you feel a stone. Do you have to get an ultrasound or imaging, or can you, and let's say it's that classic where, maybe it's not crowning, if you will, you're not seeing it, but you can feel it,
Yeah.
Can you offer something right away, or how important, do you have to, if you feel like, hey, the history fits, the physical fits, I'm pretty sure that's what it is.
Right. Yeah. If I am 99% sure that that's it, I will talk to the patient about just, going straight to a sialolithotomy, sialodocoplasty, just removing the stone through the floor of the mouth. I've had patients who have, a high deductible plan, and they know it's going to cost them a lot of money to get a CT, and it may not change what we do. And so they're just, kind of twisting my arm to be like, can't we just, it's right there. Can we just do this? And so I think it's reasonable. The big things that I talk to patients about is, because we don't have the CT ahead of time, there may be surprises, right? So, I may not be able to get it out. There may be other stones behind it. So ultimately, we may need to get some sort of imaging, or, a CT or an ultrasound beforehand. I think an ultrasound is a good alternative to CT. I like having something before I go into any sort of procedure. That would be my preference, is to have a CT going into it. But, the other thing about CT sometimes is dental artifact. And so if they have a bunch of dental work that is creating artifact on the CT, sometimes the CT won't show the stone. So sometimes it's not even helpful. And so I think it's one of those things that you talk about, and you want to be as prepared as possible before you're doing any sort of procedure. But also, if your physical, you can also trust your history and your physical exam. And sometimes you can make the patient better that day and never have to do, the imaging workup and you're done. So it's one of those things that we talk about, and, it's an option. I don't think it's a crazy thing to consider doing that, especially with the real small ones that are about to kind of come out on their own. You take it out in clinic real quick, you show the patient, you're like, oh, look, there it is. And they're like, that little thing, that's what's been causing me all this pain and agony when I eat. And, so, they're really happy patients. So it's really nice to be able to help them on the spot and make them feel better like that day. But I think, having a little bit more information is not a bad thing.
So what about, you'd mentioned, okay, you're going to express the gland to see if you can get anything out of the duct. And, sometimes you get saliva, sometimes you don't. What about the patient? You feel a stone and you get milky, turbid looking fluid or pus. Mm-hmm. Do you cool it down and then address it? Or do you address it that day? What are your thoughts on that when it's sort of maybe on the not quite infected, unless there's, maybe it is, it's about to pus, or, maybe it's kind of inflamed. It's, it's hard. The gland is hard, but you feel a stone.
Yeah. Yeah. I think that I wouldn't necessarily say that that's a contraindication to doing a sialolithotomy that day, but when things are infected and there's more inflammation, you have to be prepared that there might be more bleeding and that it may not be, as clean and nice and easy as it is, when it's cooled down. And so I think, my preference would be to, send them home on some antibiotics and maybe cool things down, get some imaging in the meantime if they haven't had it, and then maybe come back, in a week or two and kind of schedule it that way, which typically, our billing team prefers for us to give them a week or two for pre-authorization and things like that. So sometimes that is kind of the perfect sequence of events to kind of see, assess, have a plan, come back and do the intervention. But sometimes patients have driven 4 or 5 hours to see me. And it's just doesn't make sense to send them home on antibiotics and make them drive all the way back for something that potentially could be taken care of that day. So again, it's one of those gray areas where, we talk about it. And depending on if I think it's really going to be difficult, if it's a little more posterior and, maybe they're having a lot of pain with it too. And worse, there's a lot of pus coming out. I might just say you know what, let's start with some antibiotics, especially if it's their first time. Sometimes that stone has been there for a while and this is the first, sialadenitis that they've ever had. Maybe just treat it, especially if they're maybe older and more frail and maybe they're on more than one blood thinner, and it's going to be a little less straightforward, a little more challenging, a little more risky. These types of things, you might be able to say, hey, let's treat this infection. This is the acute thing that's happening right now. Maybe this stone has been there for a while and hasn't been causing you issues. And let's see what happens. Maybe the stone will continue to cause you recurrent infections henceforth. Or maybe, you were a little dehydrated, or who knows, for whatever reason, you had an episode of salivary gland infection. And once we treat it, maybe that will be the end. It's hard to know. So again, depending on the patient, I think it's reason you could argue either way.
Yeah, I think it's a great point. I think for anything we do, right, I think that's sort of not the conservative, maximal medical management is always an option. And patients are usually happy with a little extra time to kind of understand the disease process and what's going on and, feeling like they've tried some other things as well. And like you said, if you can avoid something, avoid a procedure, I feel like you're never gonna.
Yeah, there's nothing without complications. But I do, if we decide like some sort of non-procedural management, I do follow them closely. If we're just going to do antibiotics and wait and watch, then I make sure that they come back and see me probably within 3 or 4 weeks so we can kind of see how things are going. And I give them strict kind of ER precautions of like, if this gets bad, then don't sit on it. If we need to do IV antibiotics or something worse, then, let me know. Because sometimes it can be like a situation where that stone is just kind of not allowing any sort of egress of that infection. And we need to remove the stone for things to finally kind of get better.
Yeah, that's a good point as well. For your antibiotics, what do you usually like to prescribe for somebody that has no allergies?
Yeah, I usually do Augmentin if there's no allergies, and clindamycin if they're allergic to penicillins.
Do you think it matters? 7 days, 10 days?
I will usually do 10 days of Augmentin.
So let's say you do have the candidate. So the person that, has the submandibular, the stone, maybe it's not right at the duct, but you can feel it pretty well and it's not moving around on you and you can feel it and you have the imaging that you need. The stone is the stone. Then what? How do you kind of set them up?
Yeah. Let's say like, they're like, let's do it. I want to get it out. Let's take care of the problem. I need to move past this. Right. So, and if it is kind of the right size and location to consider just taking it out in the office, I will typically use, I'll do sialolithotomy. I don't have endoscopy scopes in my clinic. And so if we're doing anything in the office, that's what I'm referring to is doing sialolithotomy. So opening the duct, sialodocoplasty to kind of formalize that opening. If they really want sialendoscopy, because if it's borderline and maybe it is a little further back, or if they just are like, I'm squeamish about the idea of, an office procedure, then we kind of might lean more towards sialendoscopy and talking about that. And depending on the size and location, again, it still may end up being a sialolithotomy in the OR, if we can't get it with the scope. But if we're going to the OR, I do tend to almost always tell them that we'll at least try to, do what we can with sialendoscopy. But, that's another podcast. We don't, we're not going to talk about it today.
Check out episode 25. That's right. And we'll try to get Dr. Dave Cognetti back on the show. Follow up.
Yeah. So if we're, back to this patient that is like, all right, I'm here. Let's do this in the office. I don't mind, I'm going to be able to hold still. I'm going to be able to tolerate the feeling things or whatnot. Right.
Is your chair upright, flat?
I lay them down flat.
You lay them flat. Okay.
Yeah.
Do you do a shoulder roll?
I do like when you're at the dentist, you're laying all the way back and I sit in a chair, like at the head and I kind of, will like have them turn their head towards me. I'm usually on the right side of the patient, regardless of where the stone is. And I think that's just because I'm right-handed. And so it makes sense with my right hand kind of coming into the mouth from that side. I don't know, but I'm usually patient's laid back and I'm sitting in a chair kind of at the head. And then I'll have my assistant on the other side with, suction or being able to hand me things, right? So do you numb them up with anything? Meaning, I know we had this conversation in episode 25, which I keep referring to. Because I remember when I was a PGY4 and I injected the floor of the mouth to try to numb everything up. And all of a sudden we couldn't feel anything or find the papilla. So yeah,
I didn't know. Do you ever
You're having a flashback?
Major flashback. And so I didn't know, do you ever do hurricane spray on top or gels or anything? Or does that distort as well?
Yeah, so I might put a little bit of hurricane spray on some gauze and then put that in the floor of the mouth over it. Because I feel like if you just spray the floor of mouth, it just kind of goes everywhere, right? And so I'm trying to just kind of like anesthetize that spot. I don't know if that does anything, to be honest, because the lidocaine stings, anyway. But especially if you have someone that might be a little bit squeamish with needles, it does kind of take that edge off as far as like feeling the poke of the needle. But you do have to inject local. But you inject very small amounts so that you don't distort things, right? And since I'm not cannulating the duct, that's less important than when you're thinking about silent endoscopy in the OR. And I'm just trying to put just a little bit of local right on top of that stone where I'm going to make that incision. But I have to make sure that I'm not injecting so much that suddenly I can't feel the stone anymore, because that's problematic. That's going to make it really hard. So
I recall that problem very well, actually. I still remember it. Oh my God.
Yeah.
Oh,
so yeah, it's just, I'll use like a little 1 cc syringe with like a little 1/2 inch, like 30 gauge needle, just a little tiny, and I'll just poke right on top of the stone and do just a little dollop, a little tiny bit of local. I'll use like 1% lidocaine with epi. And then I will have the patient kind of push their tongue up to the roof of their mouth. And I will let them know, I want you to do your best, because they're going to be like moving their tongue the whole time, because people, you have a hard time, like your tongue just moves around sometimes, right? Especially when someone's telling you to stop moving your tongue. So I'll just give them something that I'm just like, push your tongue to the roof of your mouth. And what that tends to do is it keeps their tongue from wiggling around, and it also kind of brings the floor of the mouth up towards you.
I like that trick.
Yeah. And then I will use like a brown Adson, or, maybe a small hemostat, like a little mosquito, to kind of grab the stone so that it's, through the mucosa, kind of gently, just kind of so that you know where it is. Because you feel it with your finger, but then as soon as you're not feeling it with your finger, when you look, it usually is hard to see. Again, unless it's right there at the punctum, you're like, it's, somewhere in there. And so by feeling it and grabbing it, it kind of lets you see exactly where it is, right? And then I'll take an 11 blade, and I'll just go right down on top of the stone until I can feel it, because you'll feel yourself hit the stone with the tip of the blade. And then I'll just, make a small little incision right on the top of the stone. And then I'll keep holding the stone, and I'll take either some, like a codman or a mosquito with my other hand, and kind of spread that area. And a lot of times the stone will just kind of pop out, followed by, the egress of, the saliva and, all the, or pus or whatever's behind it will kind of like all start shooting out. It's nice to kind of have a handle on the stone, because if it slips, then it kind of just, you might just lose it in their mouth, especially if it's small.
They may swallow it.
So, be prepared for that. And if it's if it's very small, it's easy for your assistant to get it up in the suction too. So, be careful of that. But I tend to, I like to be able to grab it so that I can kind of show the patient, here's what it is. And, does that make sense as far as that?
Yeah.
Up to that point?
Absolutely. So have you ever had a time where you thought you were grabbing it and cut down, and it's not the stone? And then what do you do? Yeah,
you're like, poking with your 11 blade and you're not feeling it. And you're like, where'd it go? And I've had times where maybe it slides back. And so I will have the patients eat like a lemon drop or a lemon wedge or sour candy or something, and that'll kind of push it back up. I've tried that trick before, and it works pretty well to kind of like bring it back towards the front.
So they're in your office, you kind of sit them back or have them laying down wherever they're comfortable to suck on a lemon candy or something, and then you feel it, and then you can milk it out.
And then, is
that kind of what?
Well, I mean, like if I've successfully made a sialolithotomy, like if the duct is open and you're massaging the gland, it should come out. If it's not, then you haven't opened up the duct yet. And sometimes there's a little more tissue there than you think there's going to be, because you feel it and you're like, it's just right there. And especially if it's in kind of that middle third of the duct, it may be a little deeper. And after you've injected a little bit of local, there's, that's going to make it a little thicker too.
That little spaced.
Yeah. And so, it may be a little deeper than you think. But I think the key is being able to grab the stone and stabilize and be like, okay, this is where it is. Because if not, then you're kind of blindly poking around. And it's easy to just kind of like, it's because it's so small, it's easy to just kind of be poking around it.
Yeah. And do you feel like there's a certain size, incision, length that, if it's smaller than this, nothing's going to come out.
Right.
And can you ever go too long or too,
After the stone is out and you've massaged everything out, you've, done a little bit of minor, like kind of irrigation through there, you're going to do the sialolithoplasty part where you're kind of formalizing that opening. And the bigger it is, the easier it is for that part. Yeah. And so I tend to err on the side of larger because it's probably going to stenose down. And so my preference would be to open it up, at least a centimeter, even if the stone is only, 5 millimeters or something like that, because I feel like it gives me space to work because it's a lot harder to formalize an opening that's only half a centimeter. You're going to end up ripping mucosa. It's hard.
It's going to look like dog meat.
Yeah. And it's not necessary to no. It's from a physiology standpoint, the saliva just needs to flow into the mouth. And at least from when I think about it, I haven't had any patients that have noted any difference of the saliva coming out through this new opening versus how it used to come out all the way, through the punctum at the end. So I don't think it matters. I would just make like a nice opening. And if it's a little bit bigger than the punctum, then, if they develop another stone, maybe it'll pass easily on its own. And I've never had people get, it always kind of stenoses down. So I've never had it be so big that food's going to fall into it or anything weird like that.
Right.
Even with really large stones.
Are there landmarks in the mouth that you use to say, hey, this is just too posterior? Because we have to worry about the lingual nerve the further back we go, right? It's more superficial. So do you have landmarks?
Yeah. I mean, if it's really far back, if I'm palpating and I'm really almost my entire hand is in their mouth, to be able to feel the stone way in the back, that's just not going to be a good candidate to do in the office. Because you need to be able to see what you're doing. And so usually I'll tell them, you're just not going to be a good candidate to do in the office. I mean, and I'll make sure we have imaging on those patients. CT scan would be nice to kind of know if the stone is in the duct or if it's more in the gland, to kind of have that discussion of the likelihood of being able to take the stone out without taking the whole gland. But when it's really far back there, you do have to have that discussion of you might just have to lose your whole gland. But people are very sensitive about having an incision on the neck, and the risks that go along with that. And so even though it can be a lot more technically challenging to take it out through the mouth when you're dealing with a stone that's super posterior, I think in a patient's mind, it's but it's, it's coming out through the mouth. There won't be an incision out here. It's, it doesn't mean it's impossible to take out through the mouth, but it means that for me, in my hands, I don't want to try to do this in the office.
Yeah, we might be going to the OR for that.
It's just, even when it's in the middle third, that can be really challenging in the office. Yeah. I mean, my preference for the ones in the office would be the ones that are right at that distal third, where you're just kind of, they're already almost out and you're just kind of helping them come out. Those are the nice chip shots.
Yeah.
Yeah. Even in the middle third, they can be challenging.
Do you irrigate after, let's say the stone comes out? Are you washing anything out? How much saline? What do you use?
Yeah, I'll usually do a little bit of irrigation. Nothing crazy.
Yeah, because they're awake.
Yeah, you can't
You're not
drown
getting the blue gold.
I will use my little disposable ear suctions. Either a size 3 or 5, real small, and I'll kind of use some saline bullets and kind of do a little flush with. But basically, you're using drops. It's a very small volume. And then I'll use my little ear suction and kind of suction in the lumen of the duct to kind of make sure that we've kind of gotten everything. And sometimes I'll use the suction to just kind of gently probe in there as well and see if there's anything else. Because when when that metal touches a stone, I don't know, I feel like that's not as common. Usually I'm just kind of suctioning, and then you see that flow of saliva that's kind of like, that backlog of saliva that needs to come out. And then you're like, okay, this is good. That's like a positive sign for me to kind of see all that flowing out. And sometimes it comes out kind of under pressure as soon as that stone is out of the way. It's like, you're like, all right, nice.
Do you ever use, in the OR, we irrigate sometimes with Kenalog and or steroid. Do you do that in the office? Is that necessary?
Not usually. Yeah, for just a simple stone, I usually don't. I have done that for like patients who have, who we're suspecting have some sort of chronic Sialadenitis without stones, maybe some sort of autoimmune or something that's like causing some sort of ductal stenosis or something weird like that. I might offer that as an option. But if it's a stone, then I'm usually like, we just need to take the stone out and just let it heal.
Yeah. And then you do formal sialolithoplasty?
Yeah, almost always we'll throw some sutures. I will use a fluorochromic suture. I have some little like Castroviejo like needle drivers that work well for just kind of like sewing in the mouth with a patient who's awake to do each side of that opening to, basically sew that mucosa of the duct to the oral mucosa so that it's kind of created a formal new opening.
Do you think it matters though? Like, let's say at that point, the patient is just done and you're not going to get a suture in.
Right.
Can you watch them?
Yeah.
Or do you feel like...
Yeah.
I feel like the sialolithoplasty is controversial of whether you have to, don't have to, like, I don't know.
Yeah.
I'm just asking.
That's a good question. I try to get in at least one suture. If I guess it depends on the size of the incision as well. If it's bigger, I'm a little less worried about it completely stenosing and scarring together. But I'm still worried. I'm always worried.
Yeah. Those are, they're difficult patients. And if there are complications, they're not easy ones to manage, being strictures and, things like that. A recurrent stone happens. That's not uncommon. And even that, having to manage that again and something that's already been manipulated is not easy.
Oh, yeah, for sure. Yeah, because you're basically changing the anatomy of the duct kind of forever.
Yeah.
And so I really try hard to make sure that I'm at least getting a suture on each side just to try to, hold that open. But you're right. Sometimes that's probably the hardest part is being able to do that, especially in the awake patient, because they've, depending on how long it took to, get the stone out, now they're, still sitting there with their mouth open and they're getting a little antsy and their tongue's moving around.
Yeah. And maybe your local, is in the area, you know what I mean? Because we're making a tiny bleb or, on top of the stone, but where you're putting your sutures may be beyond the borders of that stone too. So
yeah, that's true.
They may be feeling more.
Yeah. And sometimes, you might have to come back and do a little bit, if they're like, ow, I'm feeling that, you might come back and put a little bit more local around your sialolithotomy. I think the other thing that can be really tricky, especially if there's bleeding.
Yeah, I was going to say.
Yeah, sometimes it's hard, to tell what is the lumen of the duct and what's, just the soft tissue in the floor of mouth. And the loupes are extremely helpful. I feel like, you kind of have Superman vision when you have your loupes on. I don't know if I could do it without loupes to be able to know, exactly what tissue you're trying to sew to what. But yeah, that can be, really challenging. And I would, I don't know, if you're not sure and you get a little disoriented and it's bleeding, it might be better to just not
call it.
Yeah, because you might make it worse if you're sewing tissue to other tissue that's not what you think you're doing.
It's like the stay sutures on a trake. We label them for a reason.
Yeah.
Because you can very easily close that opening.
Yeah. It's so it can get really tricky. And speaking of bleeding, we talked about kind of patient selection. Another discussion to be had, patients who are on blood thinners. Again, if it's that tiny stone that's already at the punctum and you just kind of need to, make a little nick to open things up and it comes out easily, you may not need to come off of your blood thinner for that. But everything else, I'll usually say, hey, we need to see if it's safe for you to come off your blood thinner for this, because that's going to make it a lot easier for me.
Yeah. And avoid the potential floor of mouth hematoma.
It's going to be easier for me and better for you, better outcomes for you if I can see what I'm doing. And usually they're like, okay, yeah, that's good. That sounds good. I want you to be able to see what you're doing.
Yeah. That's important. So let's say the procedure goes and, the stone comes out, or let's say, do you feel like you ever have situations where maybe the stone doesn't come out, but you've made a big opening, you got some milk out, like, milky saliva out? Do you feel successful in those as well? I mean, at least if anything, they can still massage the gland and continue to express. And if it's small enough, it may still come out, or how do you feel about that?
Let's see. I mean, if I haven't gotten the stone out, no, I don't feel successful at all.
Isn't the glass always half full?
I mean, yeah. Like if I haven't had this, knock on wood, I have not had this happen yet where we have to, abort an end without getting the stone out. But if that happened, then I would probably have that discussion about like, we may need to go to the operating room to do this, or depending on what the reason was for not being able to get it, I mean, if it's small, sure, there's a chance that maybe it's just too wiggly. Maybe it was moving and, went back into the gland. And once they, massage it a little bit, it might slip out. So that's certainly possible. I've had that happen with patients like in the operating room where we do silent endoscopy. We can't reach the stone. We do a little bit of a sialolithotomy, sialodogoplasty, just kind of at the punctum just to make it a little bit bigger because we've kind of dilated a little bit with the scope. And then later the patient tells me, oh yeah, like afterwards I felt the stone come out, I massaged it and it came out in my mouth. So sure, I think that happens. And that's great if that happens. But I mean, going into it, like the goal is to be able to take the stone out and be able to be like, yay, high five. And then secondarily to make sure that things heal so that there's no complications afterwards.
Yeah. I feel like we, in terms of size, you always, oh, it's so big or this and that. But the small ones, like, 1 to 2 millimeter, they're a pain and they're tricky. And sometimes they lead to more problems than you're hoping. Because I've had that happen where, you're chasing a small stone, it's causing symptoms. You go to the OR, you do endoscopy, you don't see anything. You feel like you're right as proximal as you physically can be. And then you've opened up a can of potential for strictures or, hey, we're still symptomatic. So those small ones are real.
Yeah. I totally agree. The small ones are way harder than the big ones. Like I like the biggest stone I ever removed was huge. I think I showed you a picture. It was
a dinosaur stone. I was like, is this a dinosaur tooth?
It looked like
a shark tooth?
Fossil. Like it was 5 centimeters plus. Like, it was amazing.
But that's ridiculous, Ash.
But you could feel it. Like it was a bit big. It was there. Like stones, like the hard part is usually like being able to like isolate it and find it and grab it. And so the smaller it is, the more evasive it is.
It is, yeah.
Yeah, the more likelihood of, potentially causing harm in your attempt to get it. Those are certainly the harder ones.
It's like, I'm going to need you to just deal with this for about 10 more years so we can triple the size of this. And then that way... Oh, man. Yeah. Okay. So let's get into post-op care. Do you do antibiotics? Or do you have them doing mouthwashes? What do you like them to do? When do you see them?
Yeah. When I first started doing them, I was really crazy about Paradex rinse and post-procedure antibiotics. And I've really moved away from that. I think, it's one of those things like the stone is the pathology. And once you remove that, you just let the body kind of heal and get back to normal. So unless there was some infection that was discovered after the stone was gone, it's oh, there is a lot of pus here. Or if it seems to be actively infected, then sure, I think antibiotics make sense. But I don't just routinely do antibiotics just because we did the procedure, because I don't really think it makes a difference, or at least I haven't seen that it makes any difference. And typically they feel so much better once the stone is gone.
See, that's good to know because I am one of those automatic, okay, I'm worried about sialolithiasis. I did something, but that's good to know that you don't have to do it always.
Yeah, I just tell them to make sure and massage the gland, and kind of encourage saliva to kind of flow out and through that new opening. If it's uncomfortable, if it has been recently infected, maybe they can put a little heat on it or something like that. I don't give them any sort of strict diet restrictions, yada, yada. Like I basically say you can eat what you want to eat. However, you have an incision in the floor of your mouth. And so if you're eating something acidic or sour, it might burn because, it's just like when you have a cut in your mouth, might sting and burn. So you might try to stay away from that. And I do have them just rinse their mouth out with water for the first week after they eat, with the idea being that just trying to kind of keep things clean. They can brush their teeth as long as they brush their teeth like a normal person. like we usually talk, I'm like, as long as you're like the toothbrush is on your teeth and not on the floor of your mouth where your sutures are, like I think you're going to be fine. So I've never had anybody like disrupt anything with, brushing their teeth or doing kind of just normal oral care. What else? I tell them that they have sutures in the floor of their mouth and that they will, dissolve on their own, and to just kind of try to leave them alone. And that when they dissolve away, it might break off. You might see, the knot or part of the suture in your mouth, and you can just spit that out. That's okay.
Do you see them back?
Yeah, I usually like to see them back like in, a week or two. I like to just kind of see how things are healing up and make sure that it's not closing off and stenosing. And it usually heals pretty quickly and pretty nice. It's amazing
like
how
you never
well
were there.
The mouth. Yeah, it's so amazing how well the mouth can heal. And as far as like pain, usually Tylenol, Motrin is fine. Again, most of them were having pain because of the obstruction of the stone. And once that's gone, they feel so good and they're so happy that they can eat without having pain that, I hardly ever have those patients complain about pain from the procedure.
Have you ever had any like persistent post-op swelling? Have you ever had to do oral steroids for anything like that before? Or I would imagine that should resolve. A little bit to be expected, and then
yeah, I can't think of a time when I've had any issues like that. Yeah, there might be a little bit of like bruising of the mucosa and things like that. So I tell them if you look underneath your tongue, if you look where the procedure was, it might look a little bruised or swollen or different from the other side until things heal up.
And then, do you follow these patients long term? Stones can sometimes come back. Do you expect them to just kind of come back if the symptoms represent themselves, or do you ever see them back in 6 months, or is there a reason for it? I don't know.
After I see them, at that 2-week mark or so, if things are looking good, I kind of let them go. And I tell them, this could happen again. You know where to find me. If we need to address it, we will. But I don't make them like come back and see me on any sort of regular basis. No.
Any other major like complications? We've talked about strictures. We talked about stones can come back. We talked about maybe not finding the stone. What else could not go wrong per se, but what else do we need to think about being prepared for?
Yeah. Again, like anytime you're manipulating, the duct, the punctum, there's the risk of creating just like a complete stenosis of that duct. The structures are really small. And, once you open the duct, sometimes it can just, and like we said, if there's bleeding, sometimes it can all look the same. And so I would just make sure that your patients are aware of the possibility of things being worse. If I have a patient that's really not having symptoms and it's a small stone and I'm not super confident that we're going to be able to get it easily, then we just have that conversation and say like, hey, like we could make things worse if we, go in there and incise the duct and try to sew it open. Like it could completely stenose off and you could have, some infection related to that. And that's really hard to treat. So I think patient selection is huge with this, whether you're doing it in the office or the OR or, wherever your setting is, just making sure that you have the right procedure for the right patient and that they're aware of kind of those potential complications of either, stricture and stenosis and recurrence. And I think the other thing too is there are other conditions that can cause pain in that area. I did have a patient one time the patient did have a stone, and we were able to easily remove it in the clinic. And the patient continued to have pain. And so even though there wasn't like another stone, that we kind of presumed that there was some chronic sialodenitis going on because it was still kind of in the same area, and, questionable, maybe a stone in the gland, but again, hard to see because of some artifact on the CT. But took the gland out, and the patient just continued to have some pain. And then it ended up being, like TMJ, like jaw, like from, clenching and grinding related to stress. And so I felt kind of silly for not like going into that, but we were so kind of focused on the stone, and the patient, felt confident, like it was like, oh, this is the same pain and it's there. And so I don't know, I think maybe just making sure that the pain is from the stone, which sounds silly, but like, I think we get excited. We're like, oh, there's a stone, like let's take out the stone. And so just kind of having a clear idea of making sure that the pain is coming from where you think it is. And typically patients who have salivary stones will have pain with eating. Like if it's truly causing an obstruction, they'll have pain every time they salivate. So when they're, usually when they're about to eat.
I think that's a great point because especially facial pain, neck pain, I think the history, like you said, the specific to stones and eating is probably very key and very important. And I'm also glad we brought back the patient that has a stone, but maybe completely asymptomatic, and watching them as well, because what we do, especially, interventions aren't without potential complications and risks. And that's always the worst, right? Is I think I can make this better, but then somehow we're not, and we're worse. That's the worst feeling to have.
Yeah. And you feel terrible, when a patient has a complication that is worse than their disease process was when they came to you.
I mean, and we're talking about salivary stones, but that's with anything we do, right? Even the ear tube. The kid that do they really need ear tubes? Oh, they're always on antibiotics, are they? And now they have a big perf, or now there's a cholesteatoma. I mean, there's always some, right?
Yeah,
and so
100%. Yeah.
It's, there's always something potentially. But anyway, so any final pearls, anything that I'm missing?
This was great and really comprehensive. We talked about it for way longer than I thought we were going to be able to. I thought it was going to be really short, but I guess I have a lot to say about it. But these are so fun though. Like, yes, there's, potential for complications, but these are like some of my happiest patients. And it is so rewarding to be able to have a patient like come into the office. And if you can just like fix it in the office, and then they like walk out and they're like, all right. And you see them back and they're like, yeah, it's better. Like, you're awesome. Thank you. And you're like, yeah, like it's a win and it feels good. And then, you never really see them again because I assume they're
good,
off living their best life and doing well. And so, it's just, it's different than some of your other patients that, you're managing long-term. But it's nice and they can be really fun, especially when you're taking out like a big, 5 centimeter short
dinosaur fossil. I was like, what are you sending me?
We'll have to put
maybe that will be the picture on this.
Yeah, I was so proud of that one. That one was really fun.
It'll be a headshot of the stone, the massive one from clinic. It was absurd, y'all. Oh my god! I was like, what is this?
But like so fun, and so like they can. It's even like with this, any size of them, you take them out, and you're just like, all right, nice. Got it. And then patients generally get better. So the vast majority of patients do really well. And I think doing it in the office can be a nice thing to kind of add to your tool set and to be able to kind of offer that to patients so they don't have to go to the OR, be in PO, get there 2 hours early, get checked in, get in their gown, talk to the anesthesiologist.
Get in,
and then you do the procedure and like, 20 minutes and then it's like bed. So they've spent their whole day, at the hospital. Whereas they could potentially just come in to your clinic for an hour and be done with it. So think about it. And I think having loupes is huge. I mean, I don't think I could do it without having loupes. I think, having, another set of hands, being able to have an assistant there to kind of help you with suctioning or things like that, just setting yourself up for success, start with the easier ones and then go from there. But I'm happy to be a resource for people who are interested or want to know more.
That's awesome. Well, thank you so much, Ash.
Thank you, Gopi.
I love these. For our listeners, you can find us on SoundCloud, Spotify, iTunes, Apple, and Ghana. Please follow us on Instagram and Twitter at _BackTable ENT. We love feedback. Reach out to us for topics, ideas, speakers, or if you ever want to come on the show. That's a wrap.
That's a wrap.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable ENT on Instagram, LinkedIn, or Twitter. BackTable ENT is hosted by Gopi Shah
and Ashley Agan.
Our audio team lead is Kieran Gannon, with support from
Caleb Hodson,
Josh McWhirter,
and Ness Smith-Savadoff.
Design and digital marketing led by Brian Schmitz, with support from
Taylor Spurgeon Hess.
Social media and PR by Chi Ding.
Thanks again for listening and see you next week.